So now we're going to move on and we're going to talk about under pressure. So this is a program designated and created for the neurosciences inpatient units to talk about pressure injury prevention. So how do we best prevent pressure injuries? Really, it's keeping our patients off of those areas that are at risk for pressure. So encouraging activity. So what does this mean? Sometimes we reposition our patients at least every 2 hours, sometimes more, depending if they have redness, if they have other significant risk factors that put them at risk for pressure injury. And when we're using the turn of position system, the next element that is important with why we incorporate this system for many of our patients is that there are these wedges. So what do these wedges do? They provide the sacral offloading or lifting the bottom off of the bed mattress in order to allow for air and relief of that pressure. When we talk about pressure injury and surfaces, we really need to understand we do have different types of mattresses with all of the different beds that we have. So we really want to make sure that we are choosing the appropriate bed surface for a patient who is at risk. We have beds that do have pressure injury prevention features, and we don't want to negate the fancy technology we have in some of these beds now. We also, for patients, particularly those that have spinal cord injury, we have a regimen for offloading when they are in the chair. And this can only be done in the tilt-in-space wheelchairs that are set up, prescribed by an occupational therapist, and the patient is set up by the occupational therapist for them to be seated properly in these. So once the OT has set the chair up for the patient and we are getting them up regularly, there may be some tips and cues for how to best position the patient and if they have special features with the chair. So to do the tilt in space, we need to make sure that every 15 to 30 minutes, again, depending on what protocol the patient is on, if they go in a full tilt position, then this shifts the pressure from their bottom to their back. And so this offloads the pressure, okay? And this may be beneficial. You know, they might go from a 30-minute full tilt, 30-minute upright to as short as maybe 2 minutes tilted back. But either way, this is a program that is put in place once the patients are in this type of chair. So if our patients have low or no risk, then the type of surfaces that we tend to try and target are the older Hill-Rom beds. So these are the advanced air beds. Total care beds with just a foam mattress. And again, you will see it'll be labeled or there'll be something that'll indicate that it is foam and not a low air loss mattress surface, as well as the VersaCare beds. If they don't say VersaCare Air or P500, then it is just a foam mattress as well. And unfortunately, we put a lot of our people in Jerry chairs, but we have to recognize that these recliner chairs are not a special surface. And in fact, they pose additional risk because they have a non-breathable vinyl surface, seating surface. And so that does increase the moisture risk for our patients. When our patients are at risk, we have custom OT prescribed setup wheelchairs. We have special seating cushions, so either the Rojo cushions or gel cushions. We use the P500 surface, which is a low air loss surface with the VersaCare beds. And also the sort of next step up of bed that we'll use for some of our slightly larger, maybe not needing the full bariatric size bed. But if we do implement this, we have 2 of them in the department for the acute units and an additional one, I believe, or 2 for tertiary neuro rehab, that if you have this red mattress, it also has the same properties as that P500. It just doesn't say P500 on it. If we run out of low air loss mattress systems and we have patients who are still at risk, from time to time, the unit may end up renting a mattress surface. So if that's the case, it will be the Envision. It is paid for by the unit, so we try all that we can in order to try and find a bed that we already have available to us before we go this route. If we are going with this, we do have to use one of those older mattress bed frames in order to fit this mattress. And this is for high-risk patients who, and we are treating where they already have a staged pressure injury. So when you're doing your documentation, some of the things that you can do in the patient care flow sheet is document the sleep surface. And so easy thing to do, just pull up the bottom foot part of the sheet, look at what is labeled for that type of bed, and then you can document what that sleep surface is. And then we talk about how do we prevent pressure when it comes to linens. So we've talked about the bed, we've talked about seating. The last piece is how do we maximize the properties of these beds. So first of all, you will notice that in our neuroscience units, we do not use the reusable, launderable soaker pads. And the reason for this is many, but primarily they are not a repositioning or friction reduction device versus a flat sheet or one of the Swift sheets, etc. So these soakers, they're considered, waterproof. The whole purpose is to protect the linens. However, they hold moisture against the patient's skin, and they're very stiff and very thick, and they actually negate the properties of our new fancy beds. So instead, what we use are these disposable soaker type pads. So if we have a patient with just a Swift sheet, no incontinence needs, or we can use just a flat sheet, which also is quite slippery on these bed surfaces and works very well. And you can use a flat sheet with this disposable soaker for incontinence purposes. And we saw this picture earlier when we were discussing It's Your Move. So plain sheet fitted, a flat sheet, or fitted with a disposable soaker, and then the turn position system. Now, I didn't warn you first, but these are some gross pictures in order to talk about moisture and the risk of moisture-associated skin damage. So moisture is a big component when we're looking at how at risk a patient is for those pressure areas. So in order to prevent this, our best defense is creams. So what we aim to do is trying to identify areas before there's ever redness, before is a stage 1, before we're having any issues. And anyone who is wearing incontinence products or has any element of incontinence or moisture problems, we want to make sure we start with the zinc-based creams. So Baza or not any other brand that is that zinc-based occlusive cream. Next step up is the Criticade. So this is intended where, the irritation to the skin is more significant, and there might already be an area that is open, starting to ooze or bleeding. And for this, we're going to apply it, and we don't wipe it off entirely every time we change the patient. So what we do is we'll clean up if there's, urine or stool. We will dab all around, clean off the excrement, etc., and then just dab and then add some more Criticade on, but we're not going to try and push hard and wipe it. It creates almost like a second skin in order to protect that fragile area. And then the last cream that we have available to us, and this is again used with nursing discretion, it is not required a doctor's order for it, is the calmoseptine. So calmoseptine is great because if you have an area that is red, itchy, irritated, it has a soothing property from calamine, but also it is soothing because it does have a little bit of antihistamine and analgesic component to it. So what is happening with our patients in that they encounter these pressure problems? So ultimately it comes down to friction and shear. And so what shearing is the weight of the body and all of the body tissues shifting slightly when we are changing position in bed, particularly when we're raising the head of the bed. And what happens is that creates additional pressure on the sacrum and then also on the heels. And so why is pressure happening? Well, these deep tissues are pressed then against the bone. And by being squeezed like this, they are not getting oxygen and nutrients from the blood vessels like usual. And so they can't maintain their same integrity, and they start to break down. So what do we do to reduce the risk? We use friction reduction devices. We use things that eliminate the shear for our mobile patients. And that's what the friction reduction device provides us, as well as the preventing of the sliding down the bed. We use repositioning, sling and lifting instead of sliding patient on linens. And really what's important is understanding why the knees of the bed go up when we raise the head of the bed up. And this is to prevent that patient from sliding down and creating that shearing action and the additional weight on their buttocks. So ideally, we want the knees to go up because that creates that V shape and it doesn't allow the patient to then be sliding down. So when we're positioned in bed, this first picture is intended to show a lady who is a little bit slumped down, and most of the beds have a hip marker or a trochanter marker, which you can see with this yellow line. And so in this case, when we have her in a good position, now of course she's looking happy and smiley, is that now instead of it across her abdomen and her hips are down lower, now we have her so that she is right at the point of the bed where it folds. And so she is folding in the right spot too. One last piece that you may not have encountered before, or maybe you've been doing it and didn't know it had a fancy name, but it's called the trunk release maneuver. And so in this picture, we can see that there's two therapists using a slider sheet in order to do this. However, this is also easily done either when a patient's in bed or once they've been seated in their wheelchair by simply reaching behind, giving them a bit of a hug, bringing the patient forward, sitting them back. So it literally is just releasing their upper body or trunk from the back of the surface to prevent that shearing from happening. So the things that we do is looking at the skin. So whenever you're helping with care, when you're bathing the patient, when you're toileting a patient, is making sure that we are keeping an eye out for any areas where there might be an evidence of a pressure injury and making sure that we are using the right equipment. For documentation as healthcare aides, you can document that sleep surface. You can document what preventative steps you've taken. If you helped apply cream to an area when you were repositioning the patient or left an area open without putting incontinence products on to minimize the number of linen layers. All of those things are very important that you can participate and assist with. We're going to shift now to the last of our topics. So we've talked about the it's removed, we've talked about pressure injury. Now we are going to talk about the restraints to the last resort or least restraint philosophy. So we identify 4 types of restraints that we encounter clinically. And really what we want to make sure is that before we are implementing any type of these 4 restraints is have we addressed alternatives? Have we addressed all the things that can be done for this patient in order to prevent having to go ahead and use a form of restraint? So one of the things that we use are alarms. We use bed alarms and also chair alarms. And so this prevents us having to attach anything to keep the patient in the bed or in the chair, but alerts us right away when they shift position, even before they are up and potentially out of the bed or chair. Another alternative to try before we instigate any kind of restraint is ask the question, would neural mitts be of benefit for this patient? So there's a number of different styles, and it depends a bit on what area gets what ordered. But the premise is that it has a portion of the mitt that is a padded soft surface, and that it encircles the hand and it attaches to the hand in order for it to not be easily removed by the patient. If we have exhausted all of our alternatives and we do have to start, the least restrictive, of course, is environmental restraint. So what do we use for this? We have some of our split doors, so doors that are openable at the bottom or the top, so that we can keep one portion, particularly the lower half of the door, closed if we want to help prevent that patient from exiting their room and maintaining them in that confined space. We also have the attachable trays for the jerry chairs or recliner chairs. Once that tray is in place, it does prevent that patient from easily exiting. So it does become environmental restraint. And then we do have the WanderGuard system or locked doors systems in our department for those patients who are ambulatory or who, once they're in their wheelchair, are mobile. If we have to initiate mechanical restraint, then we have two types that we use. You'll see the POSI or single patient type. So these are meant to be somewhat disposable. So they're used for one patient and then discarded. They're not reused on a different patient. So some of the features is that they are a quick intervention when we don't anticipate the patient is going to require these limb restraints for a length of time. And they are lower in cost, obviously. So these disposable type have a single string, they have a metal D-ring, and they have some Velcro that attaches. So it's important in the process of applying the restraint that you have the portion that goes to the patient side, that the Velcro is on the outside. Then you attach the Velcro, you run the string through the D loop, and then you actually create a bit of a V shape, and you should attach the string in a single tie to that D-ring to prevent the patient from being able to pull this restraint tighter and tighter and cut off the circulation. So there's two different ways to tie this. There's a two loop method, which it happens to be from the manufacturer information for these POSI. And so it's securing it, tying a loop, and then threading another loop through so that you again still have a quick release tie, but it's using the two loops, or you can use what's called the half hitch method. So this, you wrap around your rigid part of the bed, it folds over on itself, wrapped again, and then your loop is created. And you pull the single loop through, you give a firm tug to the patient side to ensure that it is attached and it's not going to slip. The second type of restraint that we use for mechanical restraint is the Pinel system. You may also have encountered this before, but this might be your first encounter with it. So it does look a bit intimidating when we go to first apply this and to use all of these parts. However, there are some benefits to the Pinel system. So they are less likely to be cut, ripped, or torn or removed by the patient. They have a system of strong Kevlar layer between the soft fabric, and they have metal reinforced grommets. And so what we have is a pin and cap system that the pin is then threaded through the multiple layers of the grommets in order to secure the pieces in place. These are run by a magnet, and so the magnet or the key looks like this blue tab to the left lower here. And so applied to the top of the black cap, it will release the magnet off the pin. So there is an instructional video that in order to utilize the entire system, and we're not going to run the entirety of it here, but wanted to let you know that it is easily searchable to be able to be found on YouTube. And this is what it looks like. So it covers how the locking system works, all of the different parts.
The flexibility, security, and speed of the Pinel.
And the last sort of key piece, the remainder of the putting the system together, certainly it makes the most sense for you to encounter that and practice when you're on your buddy shifts, to play with the system, to interact with patients who may have these restraints on, and have your buddy colleague or the nurses on shift with you demonstrate and show you how to apply these in real life situations. It is one key thing around the application of the limb restraints to point out that the application of these in this V shape helps maintain both the patient being unable to easily slide their hand out of it, but also allows for adequate airflow and circulation above. So how do we apply it? You can see how there's a two-hand, one with a gray tab on the Velcro and also hanging on to this white portion. And as it's applied and brought around, the Velcro attaches, but it is in a bit more of a shape of a V rather than a perfect circle around the wrist.